conduct this whole series. And I've been getting very good response from people that sitting at home, they can learn about this subject. So now a very, very important topic today is about sleep endoscopy, which we call drug-induced sleep endoscopy uh, or simple sleep endoscopy. So once we have got a patient who has got sleep apnea, who has got snoring, and we have done a polysomnography, which has told us how much is the problem of this patient. Now, this presentation is totally when we want to perform a surgery, because sleep endoscopy you only do when you want to do a surgery. So suppose if the problem is mild, moderate, severe, it only tells you this much is the problem. Tells you the quantity of the problem. It doesn't tell you the quality of the problem. Where is the problem? So polysomnography is like audiogram. It tells you how much is the hearing loss, but it doesn't tell you whether the hearing loss is sensory neural or conductive, whether the conductive hearing loss is because of ossicle fixation or because of fluid in the ear. For that, you have to do impedance. So if you take the analogy, drug-induced sleep endoscopy is like impedance, right? So sleep study is like audiogram and drug-induced sleep endoscopy is like impedance. So it will tell you where is the problem and what is to be done for that, right? So now that we know that there is a problem with this patient, the patient has a sleep apnea issue, or he has got a simple snoring, or he's got a mild, moderate, severe sleep apnea, and we want to cure this patient. If you want to give only a CPAP, then there's actually no need to do a drug-induced sleep endoscopy. But if you want to cure this patient, then you need to do what surgery is to be done on this patient. And therefore, you might have to do CT scans for the nose and, drug-induced sleep endoscopy or some kind of investigation for the pharynx. So polysomnography tells you how much is the problem, but we need to know where is the problem. Is the problem in the nose? Is the problem in the, velum? Is the problem in the oropharynx, tongue, epiglottis? So we need to know the level of obstruction or levels of obstruction, because many times there are multi-level obstructions. So what are the levels of obstruction? That we need to know exactly when we want to do surgery on the patient. So we all know that in sleep apnea, problems happen in nose region, palate region, tongue region, and epiglottis region. The basic four important areas that the problem can be. Now it could be single level, it could be multi-level. Most of the times it is multi-level. And what happens is that one level affects the other. So if the nose is blocked, effectively the pharynx will be collapsing more, the larynx will be collapsing more, everything will be collapsing more if the nose is blocked, because it's a fixed obstruction. So one site will affect the other. So if you correct one area, the other area might also improve by itself, because everything was collapsing in because of one area, and you correct the nose, say, and your tongue stops going behind, because now the patient can breathe through the nose. So that is the interaction that you need to understand. And that interaction you can understand in few ways. We know that there are static and dynamic obstruction. Nose is a static obstruction, right? Huge tonsils, which are absolutely kissing in the midline, are static obstruction. They are even obstructing when the patient is sitting, or big lingual tonsils. So if they are very small tonsils and very small lingual tonsils, they are dynamic obstruction. But huge lingual tonsils, huge palatine tonsils, nasal obstruction, nasopharynx are static obstruction. They are always present. When the patient is awake, then also they are present, so they can be easily identified. But the dynamic obstruction is only present during sleep, when the muscle tone reduces. They are difficult to identify, such as soft palate, base tongue, salpingopharyngeal fold, lateral pharyngeal wall, epiglottis. These are dynamic obstruction. They will only present when the patient is sleeping and the muscle tone reduces. So you'll not be able to see somebody's palate being collapsing when the patient is sitting with the mouth open, or his tongue collapsing when he's awake. You'll not see that, right? So you'll see that only during sleep, and therefore you have to recreate sleep. You have to see it during sleep. Now, since you cannot go into the patient's bedroom and put a scope into his nose, so you call the patient into the, OR or your hospital or your clinic, and then you sedate the patient, recreate sleep as close to natural as possible, and then examine what is happening during sleep. And that's the role of sleep endoscopy. So static obstruction like deviated septum, polyp, turbinate hypertrophy, adenoids, they always have to be treated. So we'll have a full session on the nose surgery. I think we had already, or we'll have, I do not remember. But unless you treat the nose, the CPAP pressures will be so high that the patient will not tolerate it. But if there's a dynamic obstruction, which is only during sleep, which could be either pharynx or tongue or epiglottis, then you have to decide whether a CPAP will be helpful or surgery is required. So to diagnose the dynamic obstruction, which is only during sleep, you require some kind of dynamic assessment. So how to diagnose level or levels of dynamic obstruction? There are multiple ways you can do it. Why this is important? But because if you are going to do a surgery, nose you have already assessed by the CT scan because it's static. But here it is dynamic. You have to know what is happening during sleep. So if you have to go in an, so say a ocean, the first have to know how much is the depth of the ocean. Where are some, rocks coming from the bottom of the, ocean. At some places, is the ocean not deep enough? So you need to assess the depth of the water before jumping in, before going inside. So this is how, you send a signal by a transmitter, acoustic signal, get it back. By that, you measure the depth. So obviously, similar kind of thing, not the same, but similar kind of, you want to know the depth of the problem. Before getting into surgery, you want to know how big is the, base tongue, what is happening, how much is it collapsing, how much is the epiglottis collapsing, what is happening to the vocal cords when the patient is actually during sleep, because you have not seen him during sleep, you have only seen him during the clinic. So you do not need to do this whole exercise. First of all, before starting, you do not need to do this exercise if there's no surgery anticipated. So every indication except this, that means every time you need to perform surgery on a patient of sleep apnea, you need to assess where is the problem. That means if you're going to only do the nose, then obviously you need not assess the throat. But if you're going to do any of the surgery on the pharyngeal part, then you need to assess what is happening. Even if you need to do a maxillomandibular advancement, you still need to see inside what is happening at the back of the tongue. Is it, if there's lymphoid tissue, if the tongue is excessively collapsible during sleep, then your surgery of maxillomandibular advancement will also not succeed. So in any case where you want to do a pharyngeal surgery or a maxillomandibular advancement, or any kind of sleep apnea related surgery, except the nose surgery, you need to assess the pharynx. Now, typically it has been taught that, okay, you look at Malampatti scores, you look at Friedman classification, and you'll know what is happening, and you can make a good judgment on what surgery is to be done. See, the problem is that it will give you some idea. Malampatti score and Friedman position will give you some idea, but it's not sufficient. You need to see the nasopharynx. You need to see the, hypopharynx. What you're seeing in the Malampatti and the Friedman is only the oropharynx. You're not seeing the nasopharynx. You're not seeing the hypopharynx. So how can you make a decision just by looking into somebody's oral cavity with a spatula and a torch? So this was 30 years back. In today's era, you cannot rely on, say, 20-30% assessment. You have to have at least 95-99% assessment of the airway. Correct. So now what is Malampatti and what is Friedman? Many people are confused that Malampatti and Friedman are the same. They're not the same. Malampatti classification is class 1, 2, 3, 4. All of you know it. I know about it. But it is with the tongue protruded outside. Now, if you are able to see the whole tonsil, if you are able to see the whole soft palate, it is class 1. If you're seeing partial tonsil and whole of soft palate is class 2. If you're not seeing any part of the tonsil and seeing part of the soft palate is a class 3. And if you're not seeing, even the soft palate is almost completely not visible and you're seeing only the hard palate, it's class 4. This is Malam Patti. So the difference between Malam Patti and Friedman is Malam Patti is with the tongue out and Friedman is the same thing with the tongue in. So this is a takeaway message that what is the difference between Malam Patti and Friedman? It is about Malam Patti is for difficulty of intubation and extubation. And Friedman tongue position is for the success of the surgery. That if the tongue is large, then your surgery on the soft palate will not succeed. That's what Friedman tells. But the problem is you're only seeing anterior 2/3 of the tongue. You're not seeing the posterior 1/3 of the tongue. So how can you decide about somebody, how big is the tummy, only seeing from behind? So you have to see all the aspects. So Friedman tongue position, which tells about the size of the tongue, whereas Malam Patti tells about the difficulty of intubation, extubation, are similar, but in two different positions. And both of them do not tell you about the base of the tongue. They only tell you about the anterior 2/3 of the tongue, because the sleep apnea which is not happening because of anterior 2/3 of the tongue. It is happening because of the base of the tongue. Base of the tongue is at the back of the throat. It's not in the front of the throat. So if you're looking inside from the... All right, so I got a message. Do you want to share computer audio? I've done that. So if you're looking inside from the front, you're only seeing at anterior 2/3 of the tongue, which is the food way. It's not the airway, right? You need to look at the airway, which is through the nose and which is at the back of the tongue. So the airway can only be assessed if you follow the path of the airway through a flexible scope and look from the anterior nares to the nasal cavity, to the posterior nares, to the nasopharynx, to the oropharynx, to the base of the tongue, to the larynx, to the epiglottis, right till the vocal cords. So you need to follow the path of air, and therefore the second message is that you cannot assess the airway by only having a straight, spatula tongue one thing, spatula and torch one thing. Even a nasal endoscope, a straight or an angled rigid nasal endoscope, you cannot follow the path of the airway. So you have to have flexible for sure for a sleep practice. It's impossible to do a proper sleep surgery practice without having a flexible. The flexible could be anyone, but thinner the better. So a good, nasolaryngoscope, which will definitely look till the larynx, or the flexible laryngoscope is a must for a sleep surgery practice. Now, how to diagnose dynamic obstruction? There are 5 different methods by you can diagnose dynamic obstruction. One is the flexible fiber optic in an awake patient. So we all do awake patient flexible fiber optic. The second is flexible fiber optic with Muller maneuver. So what is Muller maneuver? I'll come to you in a moment. Third is drug-induced sleep endoscopy. So you take the patient into OR, induced sleep, and then you see inside. Fourth is a sleep MRI or a dynamic MRI. You put the patient to sleep inside a MRI gantry and see what is happening. And fifth is an apnea graph. Apnea graph is a tool. I'll discuss these two things in the absolutely last. Apnea graph is a tool where you put a sensor inside the nose of the patient which goes till the esophagus. So there's an upper sensor, there's a lower sensor. Upper sensor is in the oropharyngeal area. The lower sensor is in the esophagus. So if the difference between the two sensors is not much, then it is a upper level obstruction. If the difference between the two sensors is too much, then it's a lower level obstruction. So out of this 3, sleep MRI and apnea graph has not really been very popular because of the problems associated, which I'll deal in the last couple of slides. Flexible fiber optic is very commonly used by almost everybody. Mueller's maneuver is just an extension of the flexible fiber optic awake. Drug-induced sleep endoscopy is today the most acceptable method of diagnosing, the levels of obstruction in sleep apnea. So let's discuss on these three in a little bit of detail. So what is the ideal tool? Out of these 4, 5 that we discussed, what is the ideal tool to diagnose dynamic obstruction? The ideal tool will be one which will show us the structures. What structures are causing obstruction? What is the size of the structure which is causing obstruction? And what is the size in relation to the space that it occupies? So if the tongue is large, is it large relative to the space? Is the space only narrow? Is the box narrow? If the box is narrow and the tongue is not large, but it is not fitting in because of the box, then you enlarge the box. You do a maxillomandibular advancement. If the tongue is large, but the box is, normal, then you reduce the size of the tongue. Then it has to say about the collapsibility of the structure. Suppose that the tongue is not large, but is only collapsing. Then what surgery you can do on the tongue? Nothing. You have to do hypoglossal nerve stimulation so that the tongue can retain in the correct position, or you can do some myofunctional therapy for the tongue. So ideal tool has to tell you what is the size of this, which is the structure, what is the size of the structure, what is the size of the structure in relation to the space that it is occupying, and what is the collapsibility of those structures. That is the ideal tool. Now let's look at awake flexible without sedation. So when you put a flexible in the nasopharynx and the velopharynx of a patient who's awake. Now when the patient is awake, you can see this is the soft palate, this is the uvula. But because the patient is awake, the patient can very well control the muscle tone. And therefore, though the airway is collapsible, it's not collapsing. Why? Because the patient is awake and is able to control the tone of the airway, and therefore the airway is not getting compromised. And at this point of time, you can go deep inside and look at all the areas of the airway. You can see at the velopharynx level, you can see the epiglottis, you can see the hypopharynx, you can actually make out the base tongue. But here we are only looking at what? You are only looking at structures. You're looking at the size, but you're not looking at the collapsibility because the patient is awake. So it's not collapsible. It's not collapsing because the muscle tone is, maintained. So it's very cost effective because there's no cost involved. You can just put it in the OPD, but it's not ideal because here the muscle tone is full. Patient is awake. So you do not know what happens to this when the patient is sleeping. So it's not reliable to choose the surgery that you want to do because surgery you are doing for the problem which is happening during the sleep. You're not doing a surgery for the problem which is happening when the patient is awake. So how you can assess the patient when he's awake and do some surgery assuming that what will be happening in the sleep. So you have to assess this patient during sleep, right? So this awake endoscopy is not foolproof. It's a good idea to look at the structure, size of the structure, relation to the space, all those things are fine, but collapsibility, no. With Muller maneuver. So what is Muller maneuver? It's reverse of Valsalva. So ask the patient to close your nose and ask him to take a deep breath inside. So once the patient is taking a deep breath inside with the endoscope inside, now see what will happen. On the same patient, and this video is one of my first videos. You can see it's a very old videos, but my favorite because in 2007-8, this video was taken, maybe 8-9, whatever. Now the same patient is doing the Muller maneuver. And you can see that the airway is collapsing because of the patient trying to take a deep breath inside. So the airway is actively collapsing. It's not passively collapsing. It's actively collapsing because the patient is trying to take the deep breath inside. So you can see the pattern of the collapse. In what pattern the airway is collapsing, you can very well see, and there are many studies that the pattern of collapse of the velum is similar when the patient does a Muller maneuver versus when you do a drug-induced sleep endoscopy. But in Muller maneuver, the base of tongue will not collapse because the patient is completely awake. So Muller maneuver is good to show you the pattern of collapse, good to show you the structure, good to see you the pattern of collapsibility, that too of velum only, not degree of collapsibility and not the pattern or degree of collapsibility of the hypopharynx because the muscle tone is very well maintained, right? So degree of collapse, even in the soft palate, even in the velum, you cannot make out because the patient, it's not a passive collapse. It's not happening when the patient is sleeping. It's not happening when the muscle tone is reduced. Right now, the muscle tone is pretty active. So it's an active collapse that the patient is creating, which obviously will not create during sleep. So again, Miller maneuver has its limitation. You can see the size, you can see the pattern of collapse, but you cannot see the degree of collapse, and you cannot assess the hypopharyngeal collapse because it's not at all dependent on the, because there's no relaxation. So again, Miller maneuver is very cost effective, but again, it's not ideal. You can rely it for the velum, because in velum, you are only supposed to see the pattern of collapse. Degree of collapse, obviously, you'll see more in drug-induced sleep endoscopy, but you can at least manage with a pattern of collapse, whether it is AP, lateral, circumferential, that you'll see in the Muller maneuver. But you cannot see what is happening in the hypopharynx. So again, your study is incomplete. And if you do a surgery based only on Muller maneuver, then again, your surgery is, not complete. You do not know what is happening in the epiglottis. You do not know what is happening in the hypopharynx. So for hypopharynx, if you are not going to do a drug-induced sleep endoscopy, you can rely to some extent on end expiratory position. So what is end expiratory position? You ask the patient to take a deep breath, then you ask the patient to completely exhale. And the end of expiration, and before starting of inspiration, whatever is the position of the tongue and epiglottis, that is the end expiration position. And if the tongue is completely collapsible at that point, you may get a little idea that the tongue might be contributing. But again, this is not foolproof, and world over, this is not taken, shape. People are not following this for making decisions. This is an academic tool still. So what remains is drug-induced sleep endoscopy, because you want to see the patient during sleep, and you cannot wait for endless time for the patient to sleep either in the bedroom or in the theater. So you induce sleep with drug. Now the problem is that the moment you give drug, it will give an artificial sleep. It will not give you a natural sleep. So people have done sleep endoscopies with natural sleep. People have done sleep endoscopy with proper sleep studies, level 2, level 1 sleep study, along with level 2 sleep study rather, with the endoscopy. So what can happen? You might induce an artificial sleep which is deeper than the natural sleep, or which is, shallower than the natural sleep. Your aim is to go as close to natural sleep as possible. Now, what is natural sleep? Stage 1, 2, 3, 4. 3, 4 are very deep sleep, and then REM sleep. Stage 1 is very shallow sleep. Stage 2, stage and going into stage 3. These are the maximum stages seen during a natural sleep. So stage 2 is the maximum time that the patient would spend overnight. Little bit of stage 3 and stage 4, but maximum of stage 2. REM for a very short period, after 2 to 3 hours, one burst of REM sleep will come. Then again, patient will go into stage 1, then pass into stage 2. Stage 2 will remain for maximum time, then stage 3, stage 4 for some time, then again REM sleep. This is how the cycle goes. So you should be as close to stage 2 sleep as possible. And people have done studies going right, doing the sleep endoscopy during stage 2. Now, it's very difficult to do a natural sleep, giving some drug and reading those waves. So what they did, they standardize it for anesthesia purposes. They stage into the sleep stages into a BIS format, a 0 to 100 format. 100 is a awake patient and 0 is a dead patient. And 50, you start getting anesthesia. 30 is good, plain. You should not go below 30, because then the patient is going into, a complete, good paralysis is happening during between 30 to 40. So you should not go into drug-induced sleep endoscopy between below 60. You should not be approaching towards 50. 60 to 80 is a good range, 70 plus minus 10. So if you do that, then possibly you will be able to see the best plane. So why I'm saying this at this point of time, I have a slide on this, but you have to understand that drug-induced sleep endoscopy is an artificial study. It's not a natural study, but we try to make it as good as natural by making those incorporations. So when you sedate this patient, now this is again a very old slide, light sedation. That means this time the on in that era the BIS was not available to us. So we were, just looking at what is happening inside. The patient is snoring, and in light sedation, you are seeing hypopneas. So can you see that the pattern of the collapse here is same as what we saw during Muller maneuver? But here this patient was into hypopnea. His airway was partially open, right? Now, as you go into deep sleep, now this partially open airway is gradually and gradually passively collapsing more and more. Let me fast forward and getting into a stage of complete apnea. All right. So this hypopnea is gradually, now you can see pharynx is completely closed. A complete apnea. So for me, this was very exciting during those 2007-8 era, because it was again very new in the world and we did it for the first time. So we had never seen those kind of videos. Then the patient will open up, and therefore these videos I'm showing, my first videos. Obviously, there is flaw in those endoscopies, but in 16 years time, what we do today has not changed, because human anatomy remains the same, pathology remains the same, physiology remains the same. It has not changed. Our way of looking at things, understanding has changed. Now, with the sleep endoscopy deep, you can see this how the patient is collapsing. So pardon me for the quality of these videos, because they are 16-year-old videos. So obviously our camera systems were not that great in those era, right? But this is how we used to do sleep endoscopy. And so in DISE, look at the structure, you look at the pattern of collapse and the degree of collapse of the structure, both. And the best part is that you can also anticipate the difficulty in intubation and extubation. Why? Because now you can see that whether it is only the soft palate which is collapsing, or it is the base tongue which is collapsing, is the epiglottis which is collapsing. You know what will happen when you try to ventilate this patient. You know what will happen when you try to intubate this patient. But it requires a skillful anesthetist. The drug-induced sleep endoscopy is not dependent on the surgeon as much as it is dependent on the anesthetist, because the anesthetist has to give the drug. How much to give, when to give, whether you have to give a bolus, whether you have to give a TCI infusion. I am not going into that, because there are various variations all across the world. Somebody will always use propofol, somebody will always use dexmedetomidine, somebody will always use a cocktail of both, somebody will always use a TCI, target controlled infusion pump, somebody will always give a bolus. So there are variations, but the principles remain the same, that you have to see that the patient is not over sedated, not under sedated. You have to see a full cycle, you have to see the correct level. That is same for everybody. So I'm just trying to talk on principles. So the anesthesia colleague is the most important for sleep endoscopy. And it is also not ideal. As I said, it's not ideal, but it's near ideal. See, this is the best in today's era that you can do. Obviously, in coming days, there will be better investigations to come. When they come, we'll talk about that. But as of now, today in the whole world, this is the most accepted methodology. And now what it takes, it only takes an anesthetist, an OT surgeon, and an anesthetist. So in a nursing home setting or a municipal setting, it's not costly. But it could be really costly in a corporate hospital setting, so that you have to understand. And depending on that, partially you will decide whether you want to do it, just before the surgery, or you want to do it as a separate sitting. I prefer to do it always as a separate sitting, so that I do the sleep endoscopy, I record it, I analyze it, I let the patient understand it, let the patient go home with that study, with that recording. If he wants to take a second opinion, let him take a second opinion. And then only he comes back and fills a form for surgery, consent form. Otherwise, if I do a DISE on the table and operate on that patient, he has not signed an informed consent form. His consent form was uninformed. So I do sleep endoscopy in a separate setting, and in my own setup, it's obviously not very costly. In a municipal setting, it is also not very costly. It is reliable and reproducible. Why reliable? Because you are doing it under BIS monitoring. Reproducible because you are giving the same drugs, you are having the same scope, kind of scope. So it is reliable and reproducible. Done rightly, it will give the same result in everybody's hand. But during the same episode of DISE, during the different stages of sedation, if I sedate it, deeply, the response will be more. If I sedate it lightly, the response will be little different. So you have to understand that you have to observe it for at least 5 to 10 minutes. You cannot observe it for 2 minutes and then it is over. You have to observe it for 5 to 10 minutes. You can take the recording for the most, the most representative part, but you have to observe the patient for at least 5 to 10 minutes and let him complete a whole, cycle. Let him go from mild sedation to a little moderate sedation, little deeper sedation, and then come back to the mild sedation. That whole cycle you have to at least see. So spend at least 10, 15, 20 minutes with the patient in the theater. Now, this is how the patient is. You can see the BIS monitor is fixed on the patient's head. BIS is bispectral index monitor. And you can see this video is from 2015. So again, a 10-year-old video. So I'm showing you very old videos because this is how from 2007, 8 to 15, this was after 10 years, we had reached a level of, reproducibility with BIS monitoring. And after that 10 years, more from 15 to 25. So you now 20 years of, almost 20 years of experience, 18 years, you learn a lot of things to, along the path. Then you put the endoscope inside, you put some local anesthetic and maybe some adrenaline to decongest the nose so that the patient is not disturbed. Again, there are a lot of controversy whether to use adrenaline or not, whether to use xylocaine or not. So if we go into every small point, this talk will go on for 5 hours. So I cannot cover everything. I'm covering the main important part. So this is how the patient is starting. To start with, the patient is lying flat on the OT table. And your scope, you are doing scopy from the right hand side. I stand on the right hand side. I don't stand on the head end. Some of my colleagues stand on the head end. Whatever suits you is fine. Now, after the patient is see, that time there was BIS, you are seeing, is in the range of 72. So 70 plus minus 10, 60 to 80 is the range that I have found best in my practice. I was told to start with 60. I believe 60 is a little too deep for most of the patients. You cannot go 60. High, HI patients, will start obstructing at 85 only. So for low BMI, low HI patient, you might have to go to 60. But 70, I have found, is the ideal range of BIS to plus minus 10. So as you saw, I showed you this recording from 72, gradually going down to 65. So I believe this is the best range, 70 plus minus 10. You start seeing from 80, go till 60s, early 60s. And this is the range that you have to play between and wait for 5-10 minutes and see now this patient is approaching 60. Very, very gradually. Don't give a bolus and just take him down to 50. You will see everything collapsing and your assessment will be wrong, right? So this has gone up to 54 for a while. Can you see this? So you can go up for a bit, but your assessment should be when the patient is in the 60 to 80 range. Now see, it's consistently 60 and 80, 60 to 80. This is the correct range. 70 plus minus 10 is the correct range. Therefore, I'm showing you this slide, right? Now, see what is happening inside. This video again is a 2015 video. Very, very nice video to show you what is happening. All right. So this is how you will. You can see here only the lower part is collapsing. Now, what I want to show you here is that this is the uvula. And I'll pull this last part back so that you can understand. Let me play this. See this. This is the tonsil lower pole. This is the tonsil upper pole, which is covered with the palatopharyngeus muscle. This is the tip of the uvula. This is the base of the uvula. If I play it back, what is happening? It's the base of the uvula which is going and touching at the back, not the tip of the uvula. It is the upper pole of the tonsil which is covered with the palatopharyngeus, which is going and touching at the back, and not the lower pole of the tonsil. So lower pole of the tonsil doesn't have any business with sleep apnea. It's only the upper pole and the palatopharyngeus muscle, right? So this is part I'm playing again and again, and it is the base of the uvula which is collapsing at the back. So there's no point cutting half the uvula. Either cut full or leave it completely. There's no point doing half uvulectomy. If you have to remove the uvula, you have to remove it from the base. Otherwise, you will not get a result in this. And the area which is responsible for the swallowing is much upstairs. So I will deal with that in the, I will deal more with this on the episode of palatal surgery, right? So let me just show you why DISE and how it tells you what is the kind of collapse happening, what is the structure collapsing, what is the degree of collapse happening, what is the structure in relation to the size space it is occupying, which all structures are collapsing. This is what your DISE is all about. Now, before doing DISE, you have to do a basic pre-anesthetic evaluation, because ultimately you are subjecting the patient not to anesthesia, but pre-anesthesia stage. So patient can always slip into anesthesia. So if he accidentally slips into anesthesia, then you have to resuscitate him, you have to intubate. So at least a basic ECG and basic chest X-ray is a minimum in my practice. Even if chest X-ray you do not do, ECG is a minimum you have to do. If possible, do routine investigation like CBC, chest X-ray and everything. But at least an ECG is a minimum. Without ECG, no patient ever should be taken into for DISE. Because if he's a cardiac patient and you are giving him, inducing some kind of hypoxia, you are splitting his heart. Always do the DISE in operating room or endoscopy suite. Never ever do it only in your OPD. You have to have the facility for resuscitation. Oxygen has to be ready, IV line, suction, airway, facility for intubation. So always anesthetist has to be there, a good anesthetist. Preferably the anesthetist who is going to do the surgery. He has to be there. If not possible, then the junior anesthetist who is experienced well into the DISE has to be there from the same team, so that they understand the patient well. All the resuscitation possibility has to be there, and at least there should always be a LMA available, that if you're not able to intubate, at least put a laryngeal mask airway and inflate it so that the patient can be resuscitated. Without that, no patient should be ever taken for DISE. IV line, because you are going to give drug from the IV route. Now, dexmedetomidine is the drug that we use for the last more than 10-12 years. Based with dexmedetomidine, we have stopped using propofol routinely for the last 12-13 years. Never used propofol. Only in a case where the patient is absolutely unable to sleep, then we might use a small dose of propofol. Sometimes if with a dexmed, if the patient is unable to sleep well, then injection midazolam can be supplemented. Now the dosing, you can ask your anesthetist. I'm not a great, I do not get into their field. There is a dosing schedule which is there with my anesthetist, and he gives the lectures about the dosing and all, and detailed things in our courses. But dexmedetomidine, the standard dose, 10 to 15 minutes prior to the sleep endoscopy, you have to start, and gradually, the patient will get into the sedation. If not, then you can add a little bit of midazolam. Sometimes, rarely propofol, but most of the time this will be enough. And now you will see the airway. You want to see the airway from the back. As I said, this is not the airway, this is the food way. And this is where we need to see. And we need to look at the structure. So the tonsil will be going like this, medially, upwards, and posteriorly. So when you see it from this is the movement of the tonsil, and this is the movement of the tonsil when you see it from the back. And I just showed you the same thing in the video, right? And the structures, again, the same thing, structures, movement of the structures, what is happening during sleep. This was never defined, still not defined in any paper, any journal, but this is how the movement of the structures are. The upper pole of the tonsil only creates sleep apnea. It's never the lower pole of the tonsil. And tonsillar artery is obviously at the lower pole. So you understand the importance of what I'm saying. And the Friedman classification, tongue, we have already talked about the tongue position. The tonsil size, Friedman 1, 2, 3, 4. Again, Friedman tonsil size only tells you about one dimension of the tonsil, which you are seeing from the front. Tonsil is not only a 2D structure. It does not only have a height and width. It also has a depth. It's a 3D structure. So tonsil not only has a tummy, it also has a shoulder. It also has a head. So when the depth of the tonsil is more, the upper pole of the tonsil, actually that affects more for sleep apnea. Whereas we only focus on the lower part, which affects less for sleep apnea. It is more the upper part which affects the sleep apnea. And this is what we need to understand during DISE, because if the depth of the tonsil and the height of the tonsil is more, then it will affect the retropalatal area more, right? And if you remove the tonsil, the upper pole of the tonsil, the retropalatal area, which is responsible for sleep apnea, there will be more space. Now tonsil, if large, grade 3, grade 4, mostly they are exophytic. They are only seen here, but they're not really large at the back. So they really do not compromise too much of space at the back of the soft palate. They compromise below the soft palate in the oropharynx. That is, so tonsil also has got two parts. One is the oropharyngeal part, which you see as grade 1, grade 2, grade 3, grade 4. And one is the velopharyngeal part, which is the upper pole hidden and pressing the palatopharyngeus at the back. So nobody has talked about tonsil as the velopharyngeal structure. But if you see in DISE, every tonsil is seen in the DISE being covered with the palatopharyngeus, which I showed you. Now, exophytic tonsil, but how many DISE? Very, very, very few. Right. Most of the tonsils are endophytic, so they still obstruct in the velopharynx. Even though they are not obstructing in the oropharynx, they are still obstructing the velopharynx. Right. So when this endophytic tonsil collapses, it presses on the back of the upper pole, which is the palatopharyngeus. It presses on the velopharynx like this. All right. So this is what we need to understand, that it is the upper pole of the tonsil which causes more sleep apnea than the most of the times. Lower pole almost never, and the belly of the tonsil will compromise the oropharyngeal part and not the velopharyngeal part. The upper pole of the tonsil compromises the velopharyngeal part. This is how you see it. Now see, you will call it a velopharyngeal structure. This is the upper pole of the tonsil. It is covered with the palatopharyngeus muscle, palatopharyngeal mucosa. So if you only remove the tonsil, the palatopharyngeus will be collapsing. Therefore, you have to do something to the palatopharyngeus as well. You have to remove the tonsil and you have to do something to the palatopharyngeus. Again, what something will be the palatal surgery series. Now coming to the muscles of the soft palate. Again, I will discuss in detail about these muscles in the palatal surgery, but two muscles from top, levator palati and tensor palati, you know their action. Two muscles from bottom, the anterior pillar palatoglossus and the posterior pillar palatopharyngeus, and one is the center musculus subli. So this is the action of the tensor palati, good muscle, action of the levator palati, a very, very important muscle which you do not have to damage. And we know that the area responsible for the palatal collapse is behind this. So we have to remain distal or behind this levator palati. Anterior pillar obviously never participates in sleep apnea. It's always the posterior pillar which participates in sleep apnea. I'll discuss more about this in our palatal surgery. And therefore, our aim is to operate on this part of the soft palate, which is below the levator and the tensor. Now, why I'm showing this here also, because in sleep endoscopy, what you just saw is that you have to look at all the areas: velum, nose, velum, oropharynx, tongue, and epiglottis. And therefore, the classification is that you have to understand. Now, the typical classification is that what classification? Velum, oropharynx, tongue, and epiglottis. You have to look at all the areas, what is happening there, and which you make the classification system like this: AP, lateral, concentric, oropharynx only lateral, tongue base only AP, and epiglottis AP or lateral both. Now, this is again not foolproof, because I'll come to it. There are many more classification systems. This was the original classification system, which is, accepted by the world. Then the grade of the classification, 0, 1, 2, completely open, partially closed, and completely closed. Then there's a NOHL classification system from the Italian group, Claudio Vicini group, which is the nose, oropharynx, hypopharynx, and larynx. So again, I'll not go into detail of NOHL, VOTE. These are all classification systems which have their own, merits and demerits. Now, we are working on an Indian system, which is not a classification system, but it is a reporting system. Because classification makes it quite simple. And we have seen that even in velum, there's an upper part and a lower part. So we want to see right from the tip of the nose to the vocal cords, to the epiglottis. So we have been working on an Indian reporting system. VSV is for me, Vikas, Srinivas, and Vijay. We three worked on this before. But this is a reporting system where you obviously put all the data. Which drug did you use? Did you use BIS in the or not? If you used, to what range did you use? Then you put your nose finding: nasal septum, straight, deviated, how much, right, left, S-shaped, high, anterior, whatever grade of deviation, inferior turbinate hypertrophy, before decongestion, right, left, after decongestion, right, left, middle turbinate, left, right, normal, large, nasopharynx adenoid, no, yes, no, grade 1, 2, 3, 4. The nose part, I'm not going into detail because this is a different ball game altogether. Now, the velopharynx, according to our reporting system, is divided into upper and lower part. Upper velopharynx can collapse anterior-posteriorly, is very rare. It almost never collapses anterior-posteriorly unless it is a straightaway vertical palate. Lateral is common, which is salpingopharyngeal fold, which is again graded into Agrawal's classification of salpingopharyngeal fold, grade 0, 1, 2. There's a paper on that. Lower velopharynx is what VOTE classification classifies at AP, lateral circumferential, because 90% of the time it is the lower velopharynx which is collapsing. But 10% of the times, or 5 to 10% of the times, it is also the upper velopharynx which can collapse, and which is what we have also incorporated in our system. So if only the lower part of the velopharynx is collapsing, you can simply call it a funnel kind of a collapse. Because the lower part of the velopharynx is collapsing, the upper part is not collapsing, you can call it a funnel kind of a collapse, which is the most common type of collapse. You saw that this is a funnel kind of collapse, and 90% of the collapses are like that. And here there's no levator palati, no tensor palati. You can do surgery on this part very easily. So 90% of the patients you can perform surgery without bothering about levator and the tensor. 5 to 10% have got a vertical kind of a palate. So we call them tunnel kind of collapse. Both upper and lower palate is collapsing. So in that, even the area which is formed by the levator and the tensor palati, that is also collapsing, especially the levator palati. So if you operate on that area, you will have a problem with velopharyngeal insufficiency. And obviously, the surgery is not very simple. You will not get great result. So 5 to 10% who have both. Now see, even the upper, it's a vertical palate. So even if you do surgery on the lower part, the upper part will still keep on collapsing. So these patients are not great surgical candidate. You can do a MMA where the whole thing is rotated. You can do a palatal advancement, or you can put these patients on CPAP, or you can do a suspension bridge pharyngoplasty, but still with guarded results. So this is about the vertical palate. Salpingopharyngeal fold. This is our paper. You can go through in the Indian Journal, grade 0, less than 25% to 25 to 75%, and more than 75% grade, grade 1 and grade 2. Grade 1 is 25 to 75 and grade 2 is more than 75. The salpingopharyngeal fold hypertrophy, and this is our paper. I'll not. Now the lower part is the AP collapse. Posterior collapse. What we made up of what? I'll spend, because this is made from, as you can see here, this is actually made from posterior part of the soft palate, base of the uvula, and what comes next to the base of the uvula here is the posterior pillar of the tonsil, which is the arching fibers of the palatopharyngeus, right? This one, which you're seeing here, is the arching fiber of the palatopharyngeus. So AP collapse is actually made by, okay, somebody is asking, can you mute this snoring sound? Okay, I have done it. So if you see here, somebody is asking to annotate the share content. Should I decline, Sriharsha? All right. So AP collapse is formed by the arching fibers of the palatopharyngeus and back of the soft palate. Now, same AP collapse, if I go in this part and I try to show you, you will call it a lateral collapse, right? And here you will call it a circular collapse. What I want to show you is AP lateral circular is only the predominant style, in which style it is collapsing, because the same collapse here, you can call it a lateral collapse. Here you can call it a circular collapse, and here you will call it the AP collapse. So you have to actually see the structure, because you are not going to operate on the type. You are going to operate on the structure. So you have to understand what AP means. It's a predominant type of collapse. So you have to predominantly operate on this structure. But it's not that the other structures are not contributing to the collapse. It's not predominantly contributing, right? Similarly, if you go to lateral, now it is the lateral collapse very clearly seen. Now, what is lateral collapse made up of? Let me just fast forward it. This lateral collapse was made up of the posterior part of the, or the vertical part of the palatopharyngeus. So AP collapse was made from the oblique fibers of palatopharyngeus, and lateral collapse is made up from the vertical part of the palatopharyngeus. So if you have to tackle the lateral collapse, you have to take it laterally, right? Now, this will define your basis for palatal surgery. So next lecture, you will be able to understand, if you understand this, Dr. Devan. And circular is a combination of both. Circular is a combination of both. So you have both the medial part and the lateral part of the palatopharyngeus, oblique as well as the vertical part, both are collapsing, and base of uvula is also collapsing. So everything is collapsing. So now coming to oropharyngeal part. So oropharynx has again lateral wall, which is anterior and posterior. So anterior, I'll just show you, and lateral collapse grade 0, 1, 2. So now this is hypopharynx, oropharynx. Now when you see this, the tonsil is in the anterior part of the lateral, and the palatopharyngeus is in the, the lateral pharyngeal wall behind the tonsil. So I'm talking about this part. So oropharynx is below the velopharynx. This is the velopharynx. This is the oropharynx. So the lower part of the tonsil, or the body of the tonsil, which I showed you earlier, forms the oropharyngeal blockage, which you saw in the exophytic tonsil. And this is the posterior part of the, oropharyngeal wall, which is behind the tonsil. There's no surgery designed for that as of now, right? Coming to the base of the tongue. Base of the tongue could be collapsing both, say only in the upper part, on the lower part, or in the entire part. What is upper part? Foramen cecum to the tip of the epiglottis. What is lower part? From tip of the epiglottis to the vallecula. And then it could be muscular, it could be lymphoid, it could be both. And then it could be collapsing as grade 0, 1, 2, 3 in the anterior-posterior direction or lateral direction. Lateral direction was again not defined earlier. So a lot of things we have to understand and classify in DISE. That will define what surgery you can do. Again, when you understand what differences are here, that you will be able to understand the talk on the base of the tongue in the epiglottis part you can see. Now, this is high tongue base collapse. Can you see? You can see the epiglottis, this is the foramen cecum. So when you see the filiform papilla, and you can see all this circumvallate papilla, that is the high base tongue. Right? This is my own surgical failure. 2007, I did a palatal surgery, and the patient started having collapse of the little bit of retropalatal collapse and little bit also of the upper base tongue collapse. So this is the upper base tongue, right? Whereas this is the lower base tongue. Lower base tongue, you can see mostly the lymphoid tissue, the vallecula below the foramen cecum. Above the foramen cecum is the high base tongue. Sorry, tip of the foramen cecum to the tip of the epiglottis is the upper base tongue, and from the tip of the epiglottis to the vallecula is the lower base tongue. Now you can see here the collapse is totally of the lower base tongue. Right? Generally, it is because of, most of the time it is because of the lymphoid tissue, but it can also be because of muscular tissue. So again, that you have to define. Now, this is a completely muscular base tongue. Can you see this? There's hardly any lymphoid tissue. It's purely muscular base tongue. So now lymphoid tissue is a submucosal tissue. No blood vessel will come into that. But muscular tongue is a totally different ballgame, because you will get the, lingual artery, the lingual vein. You will see the dorsal lingual artery branch of that, and you will get the big veins, dorsal lingual vein, which will bleed. This is a purely lymphoid, a large but purely lymphoid tissue. Though this patient is a very, very severe patient, even a dip of 90 or 80, 88 is completely collapsing. But this surgery is not as problematic as you have to operate on the muscular base tongue. So again, this you have to see on DISE, to the extent of the muscle, how much is the content of lymphoid tissue. Now, lateral hypopharyngeal wall, hypopharyngeal, not the oropharyngeal. So whether the lateral hypopharyngeal wall, that means behind the larynx, whether it is, collapsing or not, then you have to see the epiglottis, whether the epiglottis is collapsing or not, whether it's a primary or secondary. Primary means because of itself, and secondary because of the tongue, whether there is supraglottic involvement or not, right? So this is a primary epiglottic collapse. Now you can see that the base tongue is not contributing. It is only the laxity of the median glossoepiglottic ligament, where because of which the epiglottis is collapsing. So what is the treatment? Not cutting the epiglottis, but coagulating the median glossoepiglottic ligament. So now you understand you have to do, if the whole epiglottis is curled on itself, you might have to cut. If it is only collapsing because of the laxity of the median glossoepiglottic ligament, 7-minute surgery and you'll be able to cure the patient by glossoepiglotopexy. So this, your DISE will tell you. Most of the other investigations will never tell you. And which I told you earlier, this is the base tongue collapsing on the epiglottis. So doing a glossoepiglotopexy only will not work. You have to actually debulk the base tongue here. So, and then also do the glossoepiglotopexy, but main surgery will be the debulking of the base tongue in this case. Now, if you have a epiglottic collapse like this, lateral, then what you will do? If it is a epiglottic collapse like lateral base tongue, then what you will do? These are special situations. I used to do epiglottectomy for this, suprahyoid epiglotectomy. Of late, I have started doing glossoepiglotopexy even for these cases, and with great results. So things will keep evolving with changing. But this kind of cases where till few years back I was doing epiglotectomy. Now I'm doing epiglotopexy. I'll deal with this in the epiglottic chapter. Then while doing DISE, you can do different interventions. So closure of mouth, if you mouth close, what will happen? Now, if you see a base tongue collapse, epiglottic collapse, and you close the mouth and it stops collapsing, is there a need to do the epiglottic or base tongue surgery? No. Then what is the effect of doing a SMARC maneuver? If it is a SMARC maneuver or jaw lift maneuver, if the base tongue obstruction is improved, then you can try this mandibular advancement device. Then you can use the nasopharyngeal airway. You can, see whether the hypopharynx obstruction is improved or not. So I'll show an example, because if the nose is blocked, the mouth remains open. If the mouth remains open, mandible goes down, the hyoid goes behind, and the base of the tongue is attached on the hyoid, which goes down when the patient is actually sleeping. So when the jaw is open, the tongue is collapsing, and there's no point operating on the tongue, because you have to open up the nose so that the jaw does not, mouth does not remain open. And even if you have opened up the nose and the patient remains a persistent mouth breather, your surgery will still fail. Even if you have done a tongue-based surgery, it will still fail, because the whole thing will still keep on collapsing. So this is very important to understand, that if nose is blocked, everything will collapse. This case, the mouth open, everything is collapsing. With the mouth closed, tongue and the epiglottis, even the soft palate have stopped collapsing.
Only with mouth closed, mouth open.
With mouth open, everything is collapsing. So you can do a palate,
Mouth
waist, and
closed.
epiglottis surgery. With the mouth closed, you do not require anything, right? So only open this patient's nose and give him a chin strap. There's no surgery required. This is a great video to understand the whole concept. Obviously, every patient will not be so dramatic. It is really very good. Everything is collapsing, including palate,
Mouth
tongue,
closed.
epiglottis. And the moment you close the mouth, everything is opened at a base of 71.
Only with mouth closed.
This patient, base of 71, that means properly sedated. This patient will not require any surgery the moment you keep his mouth closed. So that's the importance of doing a proper DISE and understanding what the problem of the patient is, not just taking photograph and using it for surgery. You will miserably fail. Same thing, this is a video from, you can see 2009-10 or something. So we are putting a nasopharyngeal tube to bypass the nose and the palate both. So we are trying to assess what is happening to the pacing and the epiglottis after a nasal and a palatal surgery would have been done. So what they call interventional DISE today, 2007, 8, 9, we were already doing this. So that palate and tongue, which was earlier stopped collapsing, after you put in this, then you know that you do not have to operate the base tongue and the epiglottis. And therefore, this is extremely important to understand. Then you can use positional variations, such as you can do the DISE in head rotation, head and body rotation. And if you see the changes, I'll not go into detail of that. Mild sleep apnea, if you change the side and the patient airway opens up, then you do not need to operate. You can just put him on that particular side and ask him to sleep on that side. Give him a tennis ball in the pajama or a sleep trainer device, so that he doesn't sleep on the back and the problem will be solved. So now let me just show you a little bit of DISE. It's already 8:38. We have very less time. Now I'll just show you one full DISE.
Sleep endoscopy is monitoring. A 35-year-old male with history of snoring and choking. He's got a deviated septum on the right side. See here. Does not have on the left. The body mass index is 28, overweight, not obese. You can see the does not have. And you can see,
so I'll just take 2 minutes. At the age of 38, you can see the large adenoids.
Then at the age of 35.
Let me stop the sound here and I'll keep talking. You can see the large adenoids. 28-year-old guy, huge adenoids. Not only adenoid, now as we go down, see, you can see how narrow is the area of the velum because of the adenoids, nasopharynx. Not velum, the nasopharynx. Now we are coming to the velum. So upper part of the velum is okay. Little bit of salpingopharyngeal fold hypertrophy grade 1. You can see it coming together. That's the upper velum. And can you see the upper pole of the tonsil? This is the upper pole of the tonsil where my cursor is, pressing on the palatopharyngeus muscle. And you can see a complete collapse. Patient is into complete apnea. Grade 2 salpingopharyngeal fold hypertrophy. Complete collapse more than 75%. And as you go into the lower velum, now this is the lower velum. You can see the collapse because of the tonsil, a lateral collapse because of the tonsil. Then as you go into the hypopharynx. Let me just reach the hypopharynx again. There is a lot of lymphoid tissue on the base tongue, which is incompletely collapsing. It's not complete collapse, but there's a lot of lymphoid tissue on the base tongue. So this patient has got adenoid, tonsil, and base tongue, lymphoid tissue, lingual tonsils, all. Now we'll wait for the right. The base is 72, correct range, not over sedated. Now you see there's a incomplete collapse of the tending towards complete, but not a complete collapse. Tending towards complete, incomplete collapse. Now it is almost a complete collapse of the epiglottis because of the base tongue, which is lymphoid in nature. So I know that what all I have to do, I have to remove the lymphoid tissue, I have to do a uvulopalatopharyngoplasty, I have to do a salpingopharyngeal fold channeling, I have to do adenoidectomy, and I have to do a septoplasty because there was deviated septum, I have to do a tubnoplasty. Now for a AHI of 29, I have to do everything. Whether I do it in BMI is 27, not very, very much. I might do it young patient, male 28. I might do it in one stage. I might do it in two stages. For this patient, I have operated him in two stages. First stage, I did the nose, the salpingopharyngeal fold, nasopharynx, septoplasty, tubnoplasty. In the second stage, I have done a base tongue, glossoepiglottopexy, and modified uvulopalatopharyngoplasty. So this is how a DISE will actually give you a complete detail of what you have to do. Now, putting into classifications will not really help you to understand the whole case. You have to understand the reporting system. You have to report the whole thing. You have to understand right from the nasal tip to the airway. You have to know the BMI. You have to understand the HI. You have to know have a sample at what area, what is what BIS score, what is happening, and then you can take a correct decision on the patient's surgery. Before parting, it's already 8:42. I have to finish by 8:45 so that we have 15 minutes for question and answer. Sleep MRI. Sleep MRI, again, you can see, you can put the patient into gantry and put him off to sleep. And this is the palate, this is the base tongue. You can see what structures are collapsing, what is the degree of collapse. A good sleep MRI will give you a lot of information. But you can do almost everything with the DISE. What you will get extra in sleep MRI, you can see how much of the tongue is actually fat and how much is muscle. So you can know how much is lymphoid tissue, that you can know from the DISE, how much of the fat is there inside the tongue. If there's a lot of fat inside the tongue, then if the patient reduces body weight, the fat will be reduced and the tongue base will, help better. If it is more of a muscle and very less of fat, then even if you reduce weight, the muscle is not going to, shrink. So that is again a piece of information that sleep MRI is very important. But problem is that in the MRI gantry, most of the patients are claustrophobic. They do not sleep well unless they are very sleep apneic patient and a very sleepy patient. They will not sleep well in the sleep MRI. So for a mild, moderate sleep apnea, it's not a great tool. And if the patient goes into severe sleep apnea, if the patient goes into, if he doesn't sleep well and you try to sedate and he goes into deep sleep and is, collapsed, then his resuscitation can be tricky inside the MRI suit. So take it with a pinch of salt. In my practice, sleep endoscopy is much, much better understood and practiced. Apnea graph, I started using in 2010 and I used till 2015. I think I was the first one in the country to use that. It was a pretty expensive device, very nice, very good. But I'll tell you what the problem was. It has got a sensor which goes inside the nose of the patient, goes till the esophagus, as I told you earlier. And patient has to, it records every parameter, very nicely made. Software is very good, and it tells you whether it is obstructive apnea or, apnea or hypopnea. It is central obstructive, everything it tells you very clearly. It is upper obstructive, that means soft palate, or lower obstructive. That means whether it is the base tongue and epiglottis. So this was the era when I was contemplating between DISE and, apnea graph. And I've done a lot of studies on that. And I believe that DISE was very, very good. Apnea graph was correlating on most of the times. And the problem was that though it gives a very, very good, data, patient has to sleep with the wire inside the nose. And that is a problem because many times the patient would cough the wire out, his irritation happens. When putting the wire is fine, you put some local anesthetic and put it inside. But after the anesthesia effect goes away, in 2-3 hours time, the patient is irritated by the wire many times and used to cough it out. And that was the problem. Apart from the cost of the device and every time you have to pay for the study, then they made the wire, the every time you have to purchase a wire which is say $100 or $150. So that again added to the cost of the study. So it remains a research tool in my study. It does not, I'm not doing it routinely for sleep apnea patients. So I stop here 8:45. We still have 15 minutes for question and answer. Let me stop presenting, stop sharing. And Sriharsha?
Sir, so a few questions you have already answered during the presentation itself.
Yeah.
Like first question is Dr. Neeraj Joshi has asked, what is the sedation drug to be given during sleep?
Dexmedetomidine is what we prefer. But as I said, midazolam, maybe top up of midazolam sometime, very rare propofol, not commonly.
Then, so what is the usual cost for DISE? How much, and is it covered under insurance?
Yeah, so for different insurance, it is different. I believe many times it's not covered, right? Because if I do it in a different setting and I do not admit the patients for that, the cost in my setting is total cost is 20,000. So because 5,000 is the cost for the anesthetist, 1,500 is for the BIS monitor, and then rest is the OT charge, medication. Practically no fee for me. Nothing is left for me. But this is a tool that I want to do and learn. I have done 1,500 to 2,000 DISE last so many years. So I have learned a lot along the way. So the cost is, you cannot charge too much for a DISE. It takes, see, your resources, your OT is blocked for half an hour. Then your, the room outside the OT where the patient is observed is again blocked for 2 hours. It consumes on your resources, but if it is your own setup, this is more of starting point for a surgery. So I believe you do not look for profits into DISE. Learn the right thing, what is to be done for the patient, and then you can do your earning in the surgery. So that's how philosophy is.
Excellent point, sir. So next question, Dr. Karthik was asking, if there is a clear evidence of septal deviation on imaging, can we correct the septum first and then see improvement in snoring, or is DISE
Most of the time, so now how I do is septum is almost involved in septum, turbinate, or some kind of a nasal pathology in more than 80 to 90% of the patients. So if it is gross, what I tell them that, see, for ENT surgeons, let me tell, if you do audiogram and impedance with wax inside the ear, will it be correct? No. So you have to first remove the wax and do the audiogram impedance. Then it will give you the correct idea. So either you do the nose surgery straight away, then if obviously your symptoms will persist and we get an idea looking into the oral cavity anyways, whether you require or not. You do your sleep study endoscopy later on, that is the best. Otherwise, what we do is we do the sleep study and sleep endoscopy with the nose decongested, properly decongested. So that you simulate a nose surgery. You decongest the turbinates completely, properly, and you are simulating a nose surgery. If required, I showed you, you put a nasal airway. Now you are decongesting only into the nose. Now your nose is decongested, right? You are simulating a nose surgery. Then what will happen to the palate and base tongue? You can do the sleep study and DISE along with the nose surgery and keep it ready for the next step. So this is again one model that I use very, very commonly.
Next question, if there is AP collapse, is it compulsory to do uvula surgery? Also, is there any risk of velopharyngeal insufficiency?
So detail of this will cover in the next, when we talk on the palatal surgery. I think it's not necessary to take off the uvula. You can rotate the uvula, you can tighten the uvula, you can do something to it, or you can tighten that part from which the uvula is hanging. But if you do not do anything to it, then the snoring will not completely go away. That is for sure. So I'll detail with, I'll discuss the details in the next, whenever we have the palatal surgery seminar, we'll talk on that.
Next, how do we judge the posterolateral oropharyngeal wall, and does it change our surgical decision? Dr.
Yeah. So I have my failures. I have my failures in ENT surgeons. I'll not name, but he's a ENT surgeon from Patna. I've done a proper good surgery of the nose. I've done a proper surgery of the soft palate. He's a ENT surgeon. He came with so much of faith. He had a posterior pharyngeal collapse. And in spite of doing everything rightly, the posterior part of the oropharynx is still collapsing. So I still did a, a barbed suture for the posterior pharyngeal wall. That's an experimental thing. He's doing little better. He's not completely all right. So he can sleep much better himself, but his snoring sound, still that part is vibrating. So I'll become bolder and bolder in doing that area. That's not a very common collapse. But as I become bolder and bolder in doing the barbed suture for the posterior pharyngeal wall, I'll do more. But if you pull the whole hyoid in front, if you do a hyoid suspension, the whole lateral wall will become taut. If you do MMA, maxillomandibular advancement, the whole lateral pharyngeal wall becomes taut. Then the collapse reduces. So there's no direct surgery for the posterior lateral collapse. I'm developing one, still some time.
Do you have any special consent forms for DISE?
Not for DISE, but for sleep surgery, we have a consent form, which is on the website of Indian IASSA. It was during my tenure, 2014 to 16, so almost 10-year-old consent form. 2015, we had made this. It is on the website of IASSA for the sleep surgery thing. You can use the same thing for DISE, but there's no standard. DISE is a standard routine procedure under EA. So there's no consent form for DISE. Because it's not a surgery, but you're doing DISE, you have to take a consent. You're doing a procedure in the theater. So pre-anesthetic, you're giving some anesthetic agent. So anything can happen. A patient can even die. I mean, if you have not, so you have to have a consent.
Basic anesthesia.
Basic consent. Yeah.
So Dr. Neeraj Joshi is requesting us to have a discussion on solutions for medical and surgical management of OSA. Maybe sometime in the next.
Yeah, we'll definitely.
Dr. Herald, thanks. Very good lecture. Allowed the 3D animation. Is it available for teaching purposes?
So far, yes. I mean, it is just now. It was used for teaching purposes, but because it's my personal property, it's not there, on the net. I'll consider putting my name on it and then making it, available.
Next by Dr. SN. What is the boundary for velum and oropharyngeal lateral wall?
You're very, very right. So see, nobody has actually defined that what is the where velopharynx starts, where velopharynx ends, where oropharynx start, where oropharynx ends. It has not been defined in literature. We did our research. Therefore, see, velopharynx we have divided into, velopharynx is it's not a ring, it's a tube. So it has got an upper part and a lower part. And then the oropharynx starts. So what is oropharynx? The typical boundary is below the palate, where your soft palate, anything behind the soft palate is velopharynx. Anything below the soft palate and above the tongue is the oropharynx. Now, on the posterior pharyngeal wall, there is no boundary. So the line corresponding to the lower border of the soft palate, below that, and the above corresponding to the upper part of the tongue. This you can call the oropharynx posterior wall.
So Dr. Rajesh has posted one case scenario. The patient has undergone UPPP, nose and tongue-based reduction. Still snoring is persisting and the DISE shows multi-level obstruction. Advised auto CPAP. Even after CPAP, patient is having daytime sleepiness and snoring. What is the approach?
Very nice. So if the DISE is showing multi-level obstruction and the BMI of the patient is normal, if the box is normal, that means the facial profile is normal. if it is still showing multi-level obstruction, that means the surgery which has been done on multiple levels is inadequate.
Adequate.
If the patient is still not mouth breathing, first check on all this. If the surgery is inadequate, it can be revised. But if it is a collapsible tongue, not a large tongue, then revision is not going to help. If it is the collapsibility of every structure but not the large palate, then what you will do revising? Then you can do a hypoglossal nerve implant. If the box is small, you can do a maxillomandibular advancement. If it is collapsible, you can do a hypoglossal nerve implant. It is not yet available in our country. I am hopefully going to start it in Dubai in the next couple of months. And for this, before I part, I invite you all to the International Sleep Surgical Society meeting, which is first time going to be happening in India in February 2026. In fact, I forgot to put that slide. All the world leaders in all techniques and technology will be here. You will never ever, in the next 15, 20 years, may not get a chance again to see them in India. Right? So all of you, please join in the International Sleep Surgical Society 2026.
Yeah, you can share me that brochure, sir. We'll post it in our group.
Yes.
Next question. Dr. Dakshinamurthy is asking, would you tell us briefly the channeling of salpopharyngeal folds? Salping of pharyngeal folds.
Yeah, so basically this was my discovery. Salpingopharyngeal fold was my discovery. Channeling was done first time by me. Still, I mean, I don't think anybody has worked on this. Everybody, Dr. Claudio, 4 days back in London when I was there last week. So he said that now that I published it and published the classification, they have also started noticing and they have also started channeling. The channeling typically is done with a ultra 55 bond of coblation, Smith and Nephew, where you can go and put the channel inside for 10 to 12 seconds and gradually shrink the whole salpingopharyngeal fold. So I think we'll cover this part in our palatal surgery detail. We'll show the techniques and all.
Sir, have you ever encountered any complications while doing DISE?
So if I say no, that means I have not done enough. All right. So in my initial days, every fifth or sixth patient would go into hypoxia. Bad hypoxia. Because our anesthetists were not trained. In today's era, in my OT, it almost never happens. No complications. DISE is free of complication in today's era in my theater because my anesthetist team is very, very used to. But whenever I am demonstrating DISE live in a conference here and there where the anesthetists are not used to, patient goes into hypoxia and that is the complication. But fortunately, no patient has been, in my experience, has had to be shifted to ICU or, some of the patient had to be put in LMA and intubated. In my earlier days, a lot of these things had happened. Because we did not know. We used to use a bolus of propofol and the patient will cut. We would not understand the sleep study. Now we know that whatever is the minimum level of sleep saturation in the natural sleep, we should not take the patient too much below that. Because that is what the patient is used to. So why complications are not there? Because the anesthetists have learned the whole procedure. My whole anesthesia, there are at least 15 anesthetists, the whole team of anesthetists that works at my place, junior, senior, anybody can do a DISE now. So seniors almost never come for DISE, only the juniors do. So once your anesthesia team understands, then that will not happen.
So can we know the grades or angles of velopharynx on DISE?
So grade is 0, 1, 2, whether it is complete collapse or incomplete collapse. 2 for complete, 1 for incomplete, and 0 for no collapse. The angles, the vertical and I think I discussed it. The vertical palate, we'll discuss it again in the palatal surgery. Right? I'll discuss it again because the time is already over. I do not want to stretch it too far. This will be definitely covered completely in the palatal surgery webinar.
2 more questions, sir. Do you repeat DISE after BMI reduction, and what is your how do you counsel for weight reduction before planning for surgery?
No, so see, BMI is DISE we are seeing the pattern of collapse and the degree of collapse. By reducing the BMI, pattern is not going to change. Degree may be reduced a little bit, not too much. So repeating a DISE after reduction of BMI is just too much. See, most of the patients after doing the nose, their BMI goes down. Most of the patients. Now, what is the relation of doing nose surgery and BMI going down? Because they are sleeping better. So they are eating less. Their leptin ghrelin become better. So even if you are not a sleep surgeon, please do a good nose surgery. Do good turbinoplasty and septoplasty. Have we already done a webinar on nose surgery, Sriharsha?
No, we are not.
We'll do it next. We'll do it next. So nose surgery will do next, and the palatal will do after that. So nose surgery is extremely important. You should do a nose surgery, and there's no need to do a DISE, repeat a DISE after the procedure. No.
If the palatine tonsil in continuity with the lingual tonsil in pediatric or adult patients, will you perform both palatine and lingual tonsil surgery?
Excellent question. Excellent question. Excellent question. I will, if the lingual tonsils are very large or even little large, I know that the moment I remove the palatine tonsil, it will become more hypertrophic. So I'll do 100% both at the same time, but I will always keep the lower pole of the tonsil and the starting of the lingual tonsil area. I will never do it in a round, in a continuity. I will leave areas of lymphoid tissue untouched at the lower pole of the tonsil and the start of the lingual tonsil, that area, because if you give a circumferential raw area, your oropharynx will tend to contract. Never ever do that. You will do a very, very bad thing. But you should always do lingual tonsil and palatine tonsil at the same time. See, this I also do when I do my multi-level surgery, palate and base tongue. So you remove the tonsil, you do the palate, and you go to the base tongue. But the lateral part of the tongue never, participates. So lateral part of the tongue and lower part of the tonsil are lateral end. There's no need to touch it. Do it in the center. Do it at the upper pole of the tonsil. If you want to leave a little bit of the lower tonsil, you can go intracapsular, but never ever create a circumferential raw area. I've had a horrible patient referred from somewhere. Whole cavity was like this. Never ever do that. This is what you have to understand, that the lower pole of the tonsil never ever participates into sleep apnea. It's the upper pole. Lateral part of the tongue can never come closer enough to block it. Why you want to create a raw area in that area? Pains me when I see complications like that. So unfortunately, there's no paper written on this. It's our fault that we don't write papers. But I'm telling those who are listening, at least never do that. But always do the center part of the lymphoid tissue and palatine tonsils in the same go. Why you want to give pain to the patient twice? There's no need to give the pain to the patient twice. I think it's an excellent question. Very, very good question.
Next question. How do you decide if the closure of mouth is sufficient and if no surgery is required?
How do you decide whether the closure of mouth is sufficient? Okay, for the base tongue. So see, while doing DISE, you close the mouth of the patient and see whether the base tongue is still, base is normal. It is 70s, not 60s and 50s. If it is in the 70s, that means your sedation is adequate and your mouth is closed and the tongue is not collapsing, then you don't need to do tongue surgery. All you will need to do is a good nose and palate and give him a chin strap so that the patient learns nasal breathing and then the mouth will remain closed. Some patient will take 1 month, some patient will take 1 year. I have patients who have taken 1 year to learn mouth breathing. Therefore, do the surgery on the patients. Small kids, do operate them early. They will become bad mouth breathers. Whatever you do later on, they will not learn to breathe through the nose. Again, a very, very appeal to every ENT surgeon. It's your duty to operate the patient as early as possible so that he starts breathing from the nose.
Next question. I think this was asked previously also. When is sleep study done after OSA surgery?
Yeah, so 6 months, 3 to 6 months is the time when you should do it. See, sleep study, again in London, we discussed that AHI is not the real criteria. We have to look at many parameters. And the best parameter is the patient sleeping peacefully or not. How is his daytime, how is the quality of sleep, quality of awakefulness, right? If he's sleeping peacefully, this is the best criteria. Then his blood pressure, then his overall, health, weight going down or not. These are also the criteria. And there's a paper by Kenny Pang and Brian Rottenberg, both of which were there in London last week. And we need to work more and more on that aspect. AHI is not the only thing, right? It's like quality of hearing. Audiogram will tell you how much is the hearing, but if the quality of hearing is not good, if the patient cannot perceive, words, if he cannot discriminate words, again, that's not correct. So sleep is a little more complex.
Okay, that's all, sir, for the day.
Great, because we are already past 9, it's 9:06.
So we'll be talking about nose in the next webinar.
The next meeting, we'll decide the dates and publish it very soon. Just before leaving, I want to say thanks to, I think I saw one of my friends from Pune, Dr. Karmarkar. Dr. Sandeep, I saw your comments. Thank you for being here on a Sunday evening. And we'll see you very soon please join us again for the International Sleep Surgical Society conference next year, 2026, February 20 to 23, in 20th February to 22nd February in JW Marriott, Mumbai, Sahar. Thank you. Now you can put your...
Yeah, that's all, sir. So thank you once again, sir. We'll be announcing the date for the next webinar soon in our WhatsApp groups.
I thank you all for joining. And I'm sure those who could not join, I'm getting messages that many of my friends could not join. So
put up
I'm
the
sure
recording.
Sriharsha will give us the recording.
Yeah.
Right.